It's my pleasure to introduce the pro for specific immunotherapy, Professor Faris Zeytoun. He is So Dr. Zeytoun is the past president of the Lebanese Society of Allergy and Immunology. He's a fellow of the American Academy, American College of Allergy and Immunology, board certified in allergy and immunology, and he's currently an associate professor at the American University of Beirut. I think most of you know Dr. Zeytoun, but he has a lot of interest in immunotherapy and in particular those days in dust mites. So let's start.
Thank you, Carla. Thank you all for coming. I hate to break this nice, collaboration between the Pulmonary Society and the Allergy Society. But, somebody is daring to step into the ring with me, somebody named Nadim Kanij, to challenge me on immunotherapy for asthma. And he's going to regret it. Now, I'm starting out here, of course, at a disadvantage because I see mostly pulmonologists here. But, there won't be a decision because it's going to be a knockdown, okay? There won't be a reason for a decision. Yalla. I know. بس بالآخر يعني ما في ضرورة للجادجمنت راح يكون في knock down يعني خلاص ما في هلا بنبلش يلا. So here we go. So we're going to talk about specific immunotherapy, but we're going to gear it for asthma. And let's start first by defining what immunotherapy is all about. It has been defined basically as the administration of allergen vaccine or extracts to modify or downregulate the immune response for allergic diseases, so that when you are exposed again to the allergen, regardless of the respiratory allergic disease, you will have less and less symptoms. So it's really a simple definition. Of course, immunotherapy is indicated or effective in 4 types of diseases: allergic rhinitis and its complications, allergic asthma, which we'll talk about, insect sting allergy, and recently there's been indication for atopic dermatitis when dust mite is the culprit. But of course, we will focus in this talk on allergic asthma. Now, the efficacy of specific immunotherapy, whether it's subcutaneous or sublingual, has been proven to be effective for both symptoms of allergic rhinitis and asthma. This is just a basic summary. There's a demonstration of reduction of the use of anti-allergy medications, not only the type but also the quantity. The reduction of nasal and bronchial allergen-specific broncho hyperreactivity. Of course, reduction of inflammatory immunologic markers, and also potential to prevention of the natural progression of allergic manifestations. As far as the mechanism of action of immunotherapy, we won't go too much into that, but basically what we are trying to do is bringing back the immune system to normal. We're trying to deviate it back to what we call a T helper 1 system. When your immune system responds to the allergen propagation through production of Th1, you don't get the Th2 cytokines that eventually lead to the production of effector cells, such as the eosinophils and so forth. So you get a decrease in effector cells and Th2 cytokines. So not only that, but induces the production of what we call Treg cells, T regulatory cells, which produce interleukin 10 and transforming growth factors, which in turn shift from the production of IgE to what we call blocking immunoglobulins. And as a result of all these 2 effects, you get the production of blocking antibodies, which inhibit IgE-mediated antigen presentation, and also you prevent IgE-dependent histamine reaction, and eventually you get the clinical effect that we are talking about. Of course, there's a lot of immunological parameters, but we won't go into that. Now, let's talk about our understanding of asthma to set the stage. And the guidelines have developed as we developed our understanding of asthma. Starting back with the earliest guidelines, the expert panel reports back in the early 90s, it's been clear that it's well established that asthma is an inflammatory disease. It has been recognized that early recognition and intervention in asthma is very important. And more recently, with the new GINA guidelines in the 3rd EPR, it's been recognized that the natural course of asthma does not really seem to be altered by current pharmacotherapy. We can control it, but we cannot alter the natural course. And the emphasis now is on individualized treatment for asthma. Now, of course, asthma is not one disease. There's a heterogeneity of asthma. There is variable amount of different types of inflammation. There are phenotypic differences. Now we are talking about different phenotypes of asthma. This is what I would talk. That's why we need individualized treatment. Of course, gene-environmental interactions play a big role, such as viral respiratory infections, pollution, prematurity, but also the development of sensitization and atopy. As a matter of fact, allergy and atopy is the single most important factor in the development of allergic asthma. Thus, this is why we need individual therapy. One size does not fit all. And there's a consensus that daily long-term control medications do not, like I said, alter the underlying inflammation and long-term consequences of asthma. So when we look at the guidelines for asthma, of course, you all are familiar with these intermittent and persistent and mild and moderate and severe. We're not going to go over the treatment for asthma. I'm just going to focus on where immunotherapy has been indicated, and it's been indicated in steps 2 to 4. In other words, we are talking in the persistent types of asthma, especially the mild to moderate asthma, and even at children as young as 5 years of age. And this is an indication that's been placed in guidelines. Same thing for older children and adults. Again, immunotherapy is considered in steps 2 to 4. Now, it doesn't say you do it because medications are not effective. There are other reasons why you do it. But if we're going to do it at all, there are certain places where we do it. We don't do it here in severe asthma. This is where we use omalizumab, but we do it in earlier steps. So in summary, if you look at the ARIA guidelines, again, immunotherapy has been placed in the mild persistent to moderate to persistent, slightly into the severe persistent, but we're talking basically the persistent and the mild to moderate category of asthma, not the severe irreversible type. Again, it's very important, again, as the ARIA guidelines say, that specific immunotherapy does not take the position of being an alternative or the ultimate treatment, but it represents a supplement to drug treatment, especially when used early on in the disease process. So I hope all this is clear to set up the stage. So now that I've set up the stage for you, my position, of course, and I think anybody's position that when you look carefully at the data, I'm, of course, pro using immunotherapy for allergic asthma, but only after appropriate consideration and evaluation of specific factors. So it's not like, general consideration. We have to consider certain conditions. What are those conditions that we should consider? Of course, we have to look at the asthma phenotype. We give as allergic immunotherapy, if we're going to give it, we give it for allergic asthma, especially when there's concomitant allergic rhinitis. We do it, like I said, to mild to moderate persistent cases, not to severe, irreversible, or uncontrolled. We do it for controlled and stable medications. We don't do it just because if the patient is uncontrolled. We supplement it to get an alternative treatment than medications. We have to look at the patient characteristics, the age of the patient, the education level. Are they willing to comply with the treatment? Of course, some patients have a preference. We should give the patient a preference. We cannot just tell the patient, you have to, there is no hope for you. Of course, we have to look at concomitant conditions or lack thereof. If a patient has cardiovascular disease, they have autoimmune conditions, they have malignancies, you have to look at the whole picture. We have to look at the risk assessment, the potential for asthma persistent and progression. This is really, to me, is the major thing. What is the potential for this child or older person that his asthma will continue and persist and he will require continuous medications? We have to look at that. Of course, a patient with a family history of asthma and atopic disease is more likely to have persistent asthma. You have to have an allergy immunology specialist availability and assessment. And this is where the teamwork comes between pulmonologists and other specialists and the allergists. We have to have communication and teamwork. And of course, you have to have the proper allergy center and clinic set up, because immunotherapy is not an easy thing to do. Other factors to consider: what is the goal of the treatment? Are we doing it to decrease the symptoms and the exacerbations in somebody who's just getting so much exacerbations, and to improve control? Or is this patient already well controlled and we're just doing it to decrease the amount of pharmacotherapy and the type of pharmacotherapy? The guidelines tell you to step down. Well, how the hell are you going to step down your treatment if you don't do anything about the cause of the problem. You want to prevent, the other purpose is you want to prevent the progression or persistence of the disease. You know, the patient is well controlled, he's doing very well, but we want to do something long term. And of course, we do it also, we have to think about avoidance of the development of asthma. Are we doing it because we want to avoid the development of it down the road? So we have to consider all these factors to consider. Now, to really understand why immunotherapy works for asthma, all you have to do is look at the asthma allergic rhinitis link. We've talked, you know, ad lib about ARIA and allergic rhinitis and asthma, and everybody here is familiar with this story. But you know, this story is not just a matter of just giving nasal steroids and just improving the asthma, although it does work. There is a significant connection, and the connection is systemic. It's immunologic. When a patient with allergic rhinitis is exposed to an allergen who also has asthma, not only these mediators are released into the nose and the lungs, but they also induce the production of what we call progenitor cells. You know, the cytokines are produced, they go to the bone marrow, they produce eosinophils and basophils and other chemical mediators, and then through the action of what we call adhesion molecules and chemotactic factors, brings back these inflammatory cells back not only into the nose, but into the lung. So really the link is a systemic link. It's not just a simple upper-lower airway physiological link. It's a systemic link. And this is why when you treat systemically, you know, by common sense, you should have a systemic result. Now, as far as the connection, we know that allergic rhinitis patients have increased bronchial hyperresponsiveness, even though they don't have asthma. Well, of course, then the patient with both, of course, the rhinitis is going to induce bronchial hyperresponsiveness. We know that when we challenge a patient with an allergen in the nose, we're going to induce bronchial hyperresponsiveness that will persist even 6 hours after the challenge. And we also know from all these lectures we've heard that treating allergic rhinitis decreases asthma-related resource utilization. In other words, treating allergic rhinitis improves asthma. So now that we know that, what is the implication for immunotherapy in asthma? For a patient with allergic rhinitis and allergic asthma who meets the indications and considerations for allergen immunotherapy. Well, if we take a patient like that, and let's go by logic. So untreated allergic rhinitis worsens asthma or triggers asthma attacks. Treating allergic rhinitis improves asthma. Anybody disagrees about that? Allergen immunotherapy is effective for asthma, for allergic rhinitis. I don't think anybody can doubt that. I didn't go over the data. So by logic, it will be expected then that allergen immunotherapy in that same patient will also be effective for his or her asthma. As a matter of fact, I think this is the reason why it's effective, because you are improving the rhinitis to begin with. And this is the point that we have to keep in mind and when we talk about it. Okay, this is logic, this is common sense, but what about evidence-based medicine? What does that tell us? Does it really do it? Well, let's look at meta-analysis. You know, meta-analysis are the best data that we have. This is an earlier study back from the 1990s where they looked at a meta-analysis of good 20 prospective randomized placebo-controlled trials for immunotherapy for asthma published over 30 years. And they showed highly statistically significant improvement in the odds of reduction of medications, symptomatic improvement, decrease in hyperreactivity. It was concluded that you need 33 similar studies with negative results to negate these published positive results. An odds ratio of over 1 indicates a positive result, and as you can see, reduced asthma symptoms, reduced medication use, improved pulmonary function, all was demonstrated in this meta-analysis. Another study back in 2000 where they looked at 24 studies, again, that met excellent criteria. The results, immunotherapy was judged to be effective in 17 out of 22 studies. 71% of studies it was effective. It was judged ineffective in 17% and equivocal in 3. So overall, immunotherapy was effective in a population of patients, not all patients. This is why I go back to choosing the right patient. with allergen-triggered asthma. And more recently, in 2005, a huge meta-analysis of all meta-analysis, again published by Abramson, a Cochrane library. This is a study looking at dust mite immunotherapy trials. You're looking at the standard mean difference, and you can see anything to the right of the line means no effect, anything to the left of the line means positive effect, and all the studies basically were to the left of the line. Same thing for pollen immunotherapy. Again, we see the same thing, everything to the left of the line. So we are talking about evidence-based medicine if this is the way you like to look at things. Now we have sublingual immunotherapy. What about sublingual immunotherapy? Does it also work for allergic asthma? This is, again, a meta-analysis looking at patients 3 to 18 years of age, published in Chest. Again, you look at the standardized mean deviation, symptom scores. Again, everything is to the left. Medication scores, again, everything is to the left. So, logically speaking, immunologically speaking, epidemiologically speaking, and evidence-based speaking, everything points to effectiveness in asthma. Knockdown number one. You want me to continue, Dr. Kanj, or you have enough? Okay.
Okay.
Okay. All right. You want to get up and continue? I'll continue. I'll give you another reason why you should consider immunotherapy for asthma.
Do you want to continue, or we do the con and then the discussion with your slides?
No, I'm not
no,
finished
you
yet.
continue. Okay.
I'm not finished yet. بدي خلص عليه.
Okay.
بعد عندي 10 دقايق ليك. ايه عندنا وقت, don't worry. The other reason to consider immunotherapy is for the potential prevention of asthma onset or persistence. Here we're talking about preventative aspect. We talked about treatment, now we're talking about prevention. To really understand this, you have to go back to the natural history of asthma. Of course, asthma is a multifactorial disease. I'm not saying all asthma is allergic. Of course it's not. You know, viruses, genetic factors, atopy and non-atopy, prematurity, smoking, environmental pollution, all this plays a role. Of course, viruses, along with allergy, has been shown to be concomitant factors. But what happens to childhood asthma? You can have asthma starting early in infancy. Some of it will go away by age 5, 6, 7. Some of it will start in adolescence or early or later on in age. But the ones that go away may stay away, or they may relapse, or the disease may progress. All this under inflammation remodeling is taking place. So we can go both ways. We can start early, start late. It can continue or it can remit. And we want to understand, why does it continue? Who continues? This is why when they looked at longitudinal birth cohort studies, such as the one from Tucson, Arizona, where they looked at patients over 25 years and still continuing, they were able to define 3 types of phenotypes, I would say. The classic transient early wheezers, these are the early children that 80% of children who wheeze early will probably get over it by age 3 or so. This is the viral-induced asthma. And then you have the non-atopic wheezing. These are also non-allergic patients who will wheeze and continue to wheeze, but they will probably outgrow it by adolescence or early adolescence or later on in age. And then you have the third type, what we call the IgE-associated wheezing. These are what we call the persistent wheezes. These are the allergic patients who will continue to wheeze most likely. So again, we have transient early wheezers, where these children are born with low lung mechanics, low lung function. And then you have the second types, what we call the prolonged early onset intermittent wheezing. Some of it maybe have atopic features, but usually they will get better. And then you have what we call the persistent early or late onset persistent atopic asthmatic features. These are the allergic children who will continue to wheeze. And these are the children that we are concerned about. You know, we can give these patients medications, but these are the children that we want to do something for them long term. This is why we have to go back and look at the role of allergy and sensitization. As I said, allergy or atopy is the single most highest risk factor for persistence of allergy. If you look at, again, at data, you look at school children who wheezed at any one time between age 0 to 13. And if you look at those children who also wheezed between age 5 and 7 years, what happened to those children? As you can see, the children who were non-atopic in green, they stopped wheezing, most of them. But the ones who were atopic are the ones that continued to wheeze. This is from the German cohort study. So it's very obvious here that atopic children are more likely to continue to have persistent wheezing. Speaking of our friend, the dust mite allergen, what about exposure to house dust mite allergen and the development of asthma in childhood? Now, Dr. Charpin talked about preventative measures, and I agree with him that preventative measures have to be a comprehensive approach. They are actually, there's a lot of positive data out there. He did not go into the positive results. But you have to have comprehensive avoidance measures in order for it to work, in addition to controlling indoor environmental factors. But speaking of dust mite-induced asthma, in this study, where they looked at a cohort study, and they followed these patients who developed dust mite allergy, 17 of those 35 of 67 patients had active asthma when they were adolescents. And of those who had active asthma, 16 of these patients were atopic, and all 16 were allergic to house dust mite. So, and all but one of these patients had been exposed to a high level of dust mite, over 10 microgram per gram. In other words, the relative risk for asthma was highest the higher the amount of dust mite allergen the patient was exposed to. Again, if you look at the graph here, this is the relation between the age of onset of the wheezing episode and the amount of dust mite allergen that these patients were exposed to. As you can see, the higher the dust mite allergen level in the mattress, the earlier these atopic patients started to wheeze. So again, it's just a simple example where atopy and environmental exposure, in this case to dust mite, plays a huge role, not only in symptoms, but also in persistence of the disease. Again, here's another study looking at patients who are likely to have persistent asthma, current asthma bronchial hyperreactivity. They tend to be the patients who had the highest quadrant of sensitization to dust mite. Again, goes to show you that the severity of atopy is a determinant, not only atopy, but the severity of it is a determinant of the persistence of asthma. What does that all mean? What does that all mean? It means that if we can do something early on to prevent or decrease allergy, we may affect the natural progression of allergic disease. And this is what we're talking about, the allergic march. Now, it doesn't always follow like this, where you get asthma early on and goes on, but this is the general pattern in those who become persistent asthmatics later on. Immunotherapy has been shown to prevent the development of new allergen sensitization. So if you start a patient who's already allergic, they are likely to become more allergic as time goes by. Immunotherapy decreases the amount of new sensitization. These are patients who were already allergic to dust mite. After immunotherapy, 10 did not get anything, while everybody else here got new sensitization. If you compare the sensitization to cat, dog, alternaria, again, less patients developed new allergies compared to patients who did not get immunotherapy. Again, this is another study looking at patients with asthma who got immunotherapy. Again, when they get immunotherapy, 75% of them did not become sensitized. So you prevent sensitization. What does that, and this is why probably in this study, a long-term study on children, it's a 14-year study in pediatrics. These are patients who had allergic rhinitis who got immunotherapy, and they were looked at 14 years later to see how many developed asthma, how many did not. Most patients who got immunotherapy did not develop asthma, versus much more likely to develop asthma if you did not get immunotherapy. So if you look at the red graph, these are the patients who did not get immunotherapy here. If you look at the ones who did not get immunotherapy, more of them got asthma than the ones who got immunotherapy. So this was an earlier study that demonstrated prevention of asthma after immunotherapy before the onset of asthma. Another study, this was repeated in 2002. These are patients with rhinitis who received immunotherapy for grass and birch pollen, and they were followed for 3 seasons. and they were looked to see if they developed asthma. Again, 3 years later, the number of children who developed asthma within the past 3 years was significantly higher in the control group. In other words, those who did not get immunotherapy were more likely to get asthma. The odds ratio of not developing asthma was 2.5. So again, these demonstrate that if you use it early you can prevent the development of asthma. You not prevent it completely, but as compared to placebo, it does work. Now, people say, oh, immunotherapy doesn't work. It will come back. That's not true. This is the PAT study. Looking at it 5 years later, as you can see, the same pattern still. Still no development. Still the same percentage. 10 years later, now we have data. Again, these are the patients who did not develop asthma. So it continues to work 3 years. This is a 12-year study after stopping pre-seasonal grass pollen immunotherapy in childhood. Again, 12 years later, still less development of sensitization and less prevalence of asthma in immunotherapy, after immunotherapy. So the effect of immunotherapy is sustained. What about sublingual immunotherapy? Now the allergen people are happy. I usually don't talk much about sublingual, but I'm going to talk about it here because it's been shown to work also in preventing in some cases. It's been shown here to reduce the development of asthma in children with allergic rhinitis. Again, this is the patients who got slit, did not develop asthma, as compared to the patients who did not get slit. The odds ratio of not developing asthma was 3.8. This is another slit study looking at patients who development of asthma to house dust mite. 10 years down the road, as you can see, the patients who got a slit did not develop asthma as compared to the ones who did not. And even 10 years later, the effect is still there. So in both subcutaneous and sublingual, we have data. Evidence-based data for sublingual and subcutaneous, we have evidence, what we call evidence A, in the treatment of rhinitis. But also we have evidence A for cutaneous and evidence B for sublingual for the prevention. And we also have evidence A for the treatment for both. So this is evidence-based medicine for you. This is why the WHO recommendations now recommends that immunotherapy, when introduced at early or at the onset, early phase of the disease, may modify the natural course of the allergic disease. Second knockdown. Finally, 3 more slides, just in case you want to challenge me on the issue of safety. You know, people think, oh, it's dangerous, it will kill you, blah, blah, blah. What does information say? Well, data shows that it is a safe thing. If we look at this study, for example, these are almost 3,000 patients. What are the incidence of systemic reaction? Less than 1% and no fatalities. Now, fatalities that have happened before were patients who had severe uncontrolled asthma that were getting doses at home and so forth. Another study looking at a 1-year prospective study, again, 2,000 patients, 3,000 patients, over 30,000 visits. What is the rate of reaction per visit? It's 1 in 1,000. And most of these reactions are basically cutaneous and mild, and they can be easily treated. Now, doesn't mean that there is no risk of systemic reaction. What are the factors that may increase the risk of systemic reactions? Symptomatic asthma and severe asthma. That's why, you know, we don't give it to those patients. We have to control it first. Patients who may have high degree of hypersensitivity, dosing errors, injection from new vials, beta blockers, rush immunotherapy. This is why when you take precautions and you have a good immunotherapy setup and you know what the hell you're doing, you should not have any problem. Now, what is the possible reasons for treatment, quote unquote, failure in asthma? Well, again, I go back to the improper selection of patients. If you're going to choose the wrong patients, of course you're not going to get any results. Improper detection or selection of clinically relevant allergens. People think, you know, if you just put a few things on the arm, you're going to detect everything. You know, people just don't understand what skin testing is all about, and and good allergy detection is all about. You have to have good detection. If you prescribe immunotherapy the wrong route, you know, if you give sublingual immunotherapy to somebody who's polysensitized, and you give him just to the dust mite, of course he's not going to get better. You're going to give the right immunotherapy. Okay, you have to put the right contact. You have to put the right dose. You have to give them for 3 years. You have to look at other cofactors. You have to make sure that there are comprehensive approach to it. You have to make sure that they comply with dosing regimen. And you know, there's a comprehensive approach. You don't just give them immunotherapy and tell them to go home. And of course, there's a false perception. You know, some people think, oh, I get immunotherapy after 3-4 months, I'm cured. You know, and of course it doesn't work. You know, you have to have realistic expectations of what you want to do. So immunotherapy has been around for 100 years. Remember that. If it doesn't work, it wouldn't be continuing, and it's continuing. Finally, is immunotherapy right for your asthma patient? Well, you know, I hope I showed you that strong evidence exists for both treating as well as preventative aspects of immunotherapy in asthma. You really have to keep an open mind, and you have to look at the science. And again, in medicine, there's an art and science to everything, to your decision making. Again, clinical judgment should be based on sound scientific and medical criteria, along with all these considerations that I have discussed with you. And these considerations have to take into account the patient, the parent, the treating physician, and the allergy specialist. So finally, if immunotherapy is right, then give your asthma patient a chance and take a shot at allergen immunotherapy. And leave the room now, and don't listen to what the next speaker has to say. Thank you.